Um, the guest speaker is my mentor from University of Miami. He's Dr. Charles Vogel, who received his bachelor's degree from Princeton and his medical degree from Yale Medical School. He then did his internship and medical residency at Emory University and his fellowship in medical oncology at the United States National Cancer Institute, the medical branch, which is a renowned institute. He spent 4 years at Uganda Cancer Institute, where he started the Solid Tumor Center of the Uganda Cancer Institute, studying primary liver cancer, melanoma, and Kaposi sarcoma. So on return to the United States in 1973, he started the first oncology inpatient unit at Grady Memorial Hospital at Emory. And then in 1975, moved to the University of Miami, where he was chief of the Division of Breast Cancer and also became the clinical director of that cancer center. In 1986, he left UM and was in private practice with various organizations such as SALIC and HCA. And from June of 2006 to April of 2010, he was the national advisor for breast cancer research for Aptium Oncology, with a practice of breast medical oncology at the Boca Raton Comprehensive Cancer Center. As of April 2010, he returned as professor of medicine to Sylvester Comprehensive Cancer Center of the Miller School of Medicine, and at the University of Miami Medical School was in charge of the Comprehensive Breast Center Deerfield Beach facility. I'm proud to say that as of January 2021, Dr. Vogel relocated his clinical practice and clinical research activities to the Miami Cancer Institute Plantation of Baptist Health South. And he is an internationally acknowledged opinion leader in breast cancer treatment and research with over 500 breast cancer related publications and abstract. So he has a book, if you all don't know, that is Living with Metastatic Breast Cancer, Stories, you can't see it, Stories of Faith and Hope. And today he's going to tell us about some of those stories of inspiration and hope. So welcome, Dr. Vogel. Thank you so much for being with us today.
So much, Grace, and good morning. This is sort of a welcome home to me for the day of caring. When I prepared this talk, I looked through my slide sets and found out that I had slide sets from 2004 through 2009 for the day of caring. At that time, everything was in person, and the day of caring really had about 500 people there. So it was very exciting events. So I'm happy to be home. For those who don't know me, other than Grace told you about my time in Uganda. I was loaned by the US government to the Uganda government to set up a cancer center and studied primary liver cancer. Our team was the first team to establish the link between primary liver cancer and hepatitis B. That was back in 1970, published in Lancet. We also saw about 200 patients with Kaposi sarcoma. That was between 1969 and 1973. And at that time, nobody really cared about Kaposi sarcoma in the US because it's such a rare disease. However, around about 1980, something called AIDS came along, and Kaposi sarcoma is the cancer associated with AIDS. So I had to go to the Communicable Disease Center in Atlanta and lecture to them and show them pictures of 200 patients with Kaposi sarcoma so they knew what they were dealing with. So after that, in a brief stay in Atlanta, establishing the first inpatient oncology ward in an inner city hospital at Grady Memorial Hospital, I got a momentous call in 1975 from Dr. Gordon Zubrod, who was my mentor at the National Cancer Institute. And Gordon called me up and said, "Hey, Chuck, you want to head a division of breast cancer at the University of Miami?" Because he had relocated there. So I said, gee, Gordon, I don't know anything about breast cancer. This was 1975. And he said, well, you're not the Lone Ranger. Nobody knows anything about the medical oncology of breast cancer in 1975. And so since 1975, over 45 years, I've seen every major advance that has occurred in the treatment and management of breast cancer. And I'd like to sort of give you a quick overview and run through of what was then and what is now in breast cancer treatment. First of all, over those 45 years, we have decreased the mortality from breast cancer by 40%. That's a rather staggering figure if you think about it, and the advances have been monumental during that time period. Well, how do we achieve those things, and what do we have in the way of treatment modalities? First and foremost, of course, is surgery, at least then and now. But we wonder about the future. The first paper has come out just recently from MD Anderson Cancer Center, where patients were treated up front with various types of medicines. And then when it came time for surgery, if the medicines had done their job, no surgery was done. So we're just scratching the surface of that particular new inroad. In 1975, the radical mastectomy was a deforming surgical procedure where after surgery, if you looked at the patient, the ribs could be seen through the skin. And the other part of the surgical procedure was removal of all of the lymph nodes under the arm. And about 30% of patients ended up with lymphedema or swollen arms. So that was then. But now, the vast majority of patients can be managed with lumpectomy and radiation. We're still seeing, I think, a bit too many mastectomies being done. Mastectomies still are necessary in certain patients when the disease is too far advanced. But lumpectomy and radiation has proved to be absolutely equivalent and maybe even a little better than mastectomy in overall endpoints. But what about radiation therapy? Radiation therapy then was cobalt. Then it was 6 weeks of therapy. Now we're talking about linear accelerators and more recently, the advent of proton therapy, and we have one of the best proton units in the country at Baptist. So we're able to deliver far more precise and often targeted radiation facilities. No more 6 weeks. Usually it's 3 weeks. And we have the capability of treating patients even within a week for selected patients. What about cancer genetics? 1975, we knew nothing. During the 1980s, we started to learn that BRCA1 and BRCA2 were important biomarkers of risk for the development of breast cancer. BRCA carriers have up to an 86% chance of developing breast cancer and about a 46% chance of developing ovarian cancer. Well, until 2015, all we had was BRCA1 and BRCA2 because there was a monopoly, and the Supreme Court broke down that monopoly. And now we are able to test for up to 90 genes, even more, but there are about 90 genes that are associated with all breast cancers across the board. And there are about 9 or 10 specifically that we test for breast cancer risk. Back then, in 1975, our overall philosophy was one shoe fits all. Breast cancer was breast cancer, Everybody got a radical mastectomy. And we were just starting to investigate the possibility of giving drug therapies, either hormonal, chemotherapy, or both, to try to increase the likelihood of cure. So that was back in 1975. Now we have 5 subtypes of breast cancer, with the likelihood that we will be discovering many more subtypes in the years to come. So our therapy is becoming far more individualized. No more one shoe fits all philosophy. But what about the advances in Grace and my subspecialty, and that's medical oncology? Surgery and radiation, as of now, still remain the mainstay of treatment, but different types of drug therapies are being used to help in early stage disease and certainly in metastatic disease as well. But what tools do we have? The medical oncologist deals with anti-hormonal therapy, chemotherapy, which is the second scariest word for everybody after the word cancer. We have various targeted therapies, and you've already heard about Herceptin from our survivor story. I was privileged to be one of the pioneers in the early phases of Herceptin clinical trials development back in 1995. And I still have patients with metastatic disease from 1995 treated with Herceptin and other types of anti-HER2 drugs. Today, we also have immunotherapy and many other types of therapies on the horizon that we can use. But what about starting with early stage disease? How do we use drug therapies of various types in early stage breast cancer? 70% of our patients are estrogen receptor positive. And for those patients with early stage disease, anti-hormonal therapy is a mainstay of treatment to try to prevent the development of recurrences in the bones, liver, lungs, brain. Chemotherapy, that dread word, chemotherapy. We still use chemotherapy, and chemotherapy is very important, and especially in certain subsets of breast cancer. In HER2 positive disease, early stage chemotherapy and targeted therapies are used up front, and it's the same for triple negative breast cancer. By upfront, I mean for the vast majority of patients with HER2 positive and triple negative breast cancer, we give chemotherapy, often with targeted therapy in the case of HER2, or immunotherapy in the case of triple negative breast cancer. And with those therapies, we are able to induce a complete response of all cancer in the breast and lymph nodes in somewhere between 40 and 70% of patients. So upfront chemotherapy with targeted therapies and hormonal therapies in early stage breast cancer is important. Another major advance in early stage disease was the development of Oncotype and MammaPrint. These are genetic tests that do not test the patient, but test the patient's tumor. And it gives the medical oncologist quantitative availability of predictive assays to decide whether a patient does or does not need chemotherapy. The major advance here has been with the use of these prognostic tests. We've been able to reduce the use of chemotherapy in early stage breast cancer by 25% over the past decade. Another major advance. For BRCA carriers, we now have a new drug for early stage breast cancer, olaparib, that has shown to improve the overall survival of patients with BRCA tumors that have been treated with curative intent, usually with bilateral mastectomies, and sometimes with radiation as well. And after that, and maybe chemotherapy, olaparib can help to increase the cure rate of early stage breast cancer. Well, with all these advances in early stage disease, unfortunately, still patients relapse and they go to their oncologist and are told, your disease is now metastatic and therefore incurable. Not untreatable, but incurable. But as soon as that word incurable comes out, most of the patients shut off and they don't hear anything else after the word incurable. And that's why Laura Friedman and I wrote our book. It's called Living with Metastatic Breast Cancer, Stories of Faith and Hope. And it's a story of 40 patients who have just randomly chosen from my up-to-date practice. I could have chosen 40 from any phase of my overall career over these 45 years. And I could have found 40 or 50 patients just like this, who live with metastatic breast cancer for 10, 15, 20. The longest patient I have is 40 years. One of the patients that is listening today has been 23 years with metastatic breast cancer, living disease-free. Hi, Beth. Welcome. So what tools do we have for metastatic breast cancer? Well, it's the same tools that we discussed previously. Unfortunately, all my patients have my cell phone. It's on my card, and so I get calls all the time. I'll have to get back to that person. Well, anyway, what do we have for the treatment of metastatic breast cancer? We have hormonal therapy. What did we have then? Then it was tamoxifen. And now we have 5 other sorry. Now we have 5 other anti-hormones that we use, usually in preference to tamoxifen. And we have 30 more that are being studied as we speak. At that time, they were used as single agents, and now we're using them in combination with other drugs that you've seen on television nonstop. We have Ibrance, we have Kisqali, we have Verzenio. All of them work in a similar way and go beyond the scope of our talk today. Just to say that they exist and they have made a major impact on our use of anti-hormonal therapy. If patients relapse on anti-hormones and Ibrance or Kisqali or Verzenio, we have Faslodex. In addition to Faslodex, we have other drugs that we use in combination. One of them also predicted by genetic tests, a drug called Piqray. Another targeted therapy, Afinitor, is another drug that we use as part of our anti-hormonal armamentarium. After we've exhausted anti-hormonal therapies, we move on to chemotherapy. Chemotherapy, then in 1975, we had 5 drugs. Now we have close to 15 chemotherapy drugs that can be used in sequence, sometimes in combination, and are highly effective. For triple-negative breast cancer, for the most part, all we had was chemotherapy. Well, we didn't have triple-negative breast cancer in 1975. We didn't know it existed because it was one shoe fits all back then. But once we discovered the entity of triple-negative breast cancer, all we had was chemotherapy. Now we have immunotherapy, and now we also have a new type of drug, not just for triple negatives, but we have other drugs of similar classes to treat HER2 positive disease. The drug Trodelvy is a Trojan horse. There is an antibody against cells on the triple negative surface that enable us to link to a chemotherapy drug. The antibody then takes that chemotherapy drug and brings it into close proximity or into the tumor, and then the linker breaks, releasing the chemotherapy so that there is more specific killing of the tumor cells as opposed to toxicity to the host. With HER2 positive disease, we have a number of new drugs. We have Herceptin, we have Perjeta, we have Kadcyla, we have tucatinib, neratinib, lapatinib, margetuximab, and on, with many more still in development. HER2 positive disease used to be one of the subsets that had the most dreaded prognosis, and now these patients are living for many, many years beyond what was expected. Finally, even for patients with metastatic breast cancer with triple negative disease, there's another bright spot, and that is that although patients relapse quickly after surgery for triple negative breast cancer, more frequently than other types of cancer, if they make it for 3 to 4 years, they're unlikely to relapse late. So the 70% of patients who have estrogen receptor positive disease, they're the ones that relapse at 10, 15, 20 years, 25 years. But the triple negative patients at that point are probably well home free. So finally, maybe you can just put up a picture of the book cover. This is the only slide that I have. And this is a picture of the book and how you might get it. If you know patients with metastatic disease, we feel, Laura and I feel, that this is something that will provide inspiration and hope to a broad array of patients with metastatic breast cancer. And so I don't see it, but anyway, it is called Living with Metastatic Breast Cancer, Stories of Faith and Hope.
We'll get it up. There you go.
There it is. And you can see how to buy the book. And if you like it, please put it on your social media pages so that more and more patients with metastatic breast cancer can benefit from the stories therein. We think they're inspirational. With that, I'd like to close and leave time for questions.
Christina, let's close the slide, and I will send that information to everyone on this call afterwards. It's also in the chat, but I will send that directly to everyone in an email afterwards.
Thank you.
Thank you. That was very inspirational, very uplifting, and I'm sure everyone feels good. And thank you for your time. I am happy to take any questions. If you want to text them in the chat, I will ask them out loud. Or if you want to just raise your hand, we'll try to recognize you that way as well.
Can I say something?
Absolutely.
So Chuck, that was wonderful. I don't know how you summarized all that information in such a short period of time, but it's been fantastic. Really, since your trial, with the Taxol Herceptin, my first patient who had metastatic breast cancer to the bones went into a complete remission that I was like unheard of, and stayed on Herceptin for like 13 years. And then we took her off and she's still in a complete remission. So those stories of hope lead me to never say you're incurable anymore. I never say that. In fact, I wrote a little story. It says, never say never. Because like you have those stories of your amazing patients, we all have those stories with different agents, whether it's Zometa, whether it's Herceptin, whether it's these new immunodrug conjugates that we're studying. It's just amazing what's happening with stage 4 breast cancer, right? It's just so gratifying.
Yeah, I'm sure that we have actually cured many patients. I have other patients like the patient that you described I have a lot of patients who are on Herceptin, and one is on now for 23 years. Hi, Beth. Yeah,
25 years, I'm correcting you, 25 years.
sorry. So a lot of patients won't go off Herceptin. They're just afraid to do so. But as your patient was cured, another patient in the book, Andrea, went off. She had liver metastases. And after being on Herceptin for 8 years, she was 13 years disease-free. She happened to die, but she died of not of breast cancer, of some unrelated illness. So yes, Grace, you're right. I do think that selected patients with metastatic breast cancer are indeed curable. And the other major point of the book is that many patients with metastatic disease, even if not cured, can live long and productive lives free of excessive symptoms from their disease or their treatment.
Good. Thank you. I know Vivian has a question. She wants to unmute herself.
Hey, Dr. Vogel, thank you so much. I don't have a question. I just like to say how appreciative I am for your dedication, and congratulations, Beth, and anybody else that might not be recognized. My mother is 3 years with metastatic breast cancer. I'm a survivor, fortunately, but she is on Kisqali, and she just got results a week ago that the lesions are improving. So yeah, that's, she's 89 years old, and you would never know that she is living with this disease unless she shares it with you. And it's, it's a great tribute to the work that you and Dr. Wang do every day. And I'm very grateful for it.
Yeah, well, with Kisqali or Ibrance or Verzenio, with first-line anti-hormonal therapy, there's a statistic, and the statistic is that the median duration of disease control is about 30 months, give or take. But nobody is a statistic, and your mom need not be a statistic.
Yep.
And I have patients who are on Ibrance because Ibrance was the first one that we started to use. So I've got patients on Ibrance now for 6 years. So nobody is a statistic. That was actually supposed to be the second part of the title of the book. It was supposed to be Living with Metastatic Breast Cancer, You Are Not a Statistic. And since we had the 40 stories, I changed it to Stories of Faith and Hope.
That can be your second book.
No, there is no second book. I do have one out there. It's my memoirs, but most of the memoirs are mostly about Africa. They're about Idi Amin, escape stories, CIA, KGB. It's not mostly medical.
Wow.
But
You just
I
saw my
haven't
Christmas
published
gift. You saw my Christmas gift for my mother and my father. They'll take both of them.
that.
Good. Good. I see Fleur has a question, and then Beth, if you wanted to say something, we'll come to you afterwards, but Fleur.
Well, I'm one of the patients in the book, and I started Herceptin as a study back with Dr. Vogel in 1998. And it's true, we are not a statistic. I was given 6 to 18 months to live, and I said, something's got to give here. And I became Dr. Vogel's patient, and I'm here, going to be 25 years in February, living and loving life, because of research. So
Awesome.
it just goes to show, nobody knows what drug is going to work for who, and we should never give up.
Amen. All right, Fleur, over to you.
Dr. Vogel, I also don't have a question, but I wanted to thank you for your time and your sharing your stories with us here today. I am blessed to be a 20-year survivor, in part because of you. You were my oncologist 20 years ago, so thank you.
Thank you. Good to see you again. after all this time.
Does anyone else have any questions that you want to ask out loud or put in the chat? Dr. Wang, do you want to summarize or wrap it up before we go into our game that we have
Well,
for everybody?
I think what Chuck and I have seen over the years, when I started, it was only tamoxifen and chemotherapy. And to see all these new agents come, throughout the years based on research, which is really, really important. We commend all the patients that have been on research trials to get us information to help our future patients. It's just been incredible. It's just such a fascinating time. And we just had San Antonio Breast Cancer Conference where we have so many new drugs that are going to be available. It is incredible, right? It's hard to see who's going to be the first and how many drugs will be on the market in the next year, but it's just boggles your mind. All the research, and at the cellular level, they can track a tumor cell and they can track the cells around it, the macrophage, the blood vessel cell, and see and look at the genomic profiling of those cells and how they interact with each other. The detail of the research is just incredible. So it's exciting. It's an exciting time. But thank you, Chuck. You really wrapped a lot of information into a short talk. I commend you for that. There's so much information. Thank you.
Thank you.